On open angle glaucoma, the different scenarios. Usually, management of open angle glaucoma everyone must be familiar with, but we get confused when you meet a ocular hypertension patient or a normal tension patient, or when you do a cataract surgery in a pseudoexfoliation glaucoma. So that's difficulties and decision making. How can we proceed? So Dr. Smita VK will talk to us on ocular hypertension, when to treat. She is the consultant, consultant in the glaucoma department of Little Flower Hospital, Angamali.
Good morning, all. At the outset, I would like to thank Dr. Girija and KSOS for giving me this opportunity. Ocular hypertension is defined as IOP greater than or equal to 21 millimeter mercury with applanation tonometer in 2 or more occasions with normal visual field, normal optic disc, open angles, and no ocular or systemic cause of increased IOP. Ocular hypertension occurs in 4 to 10% of population over age 40 and is 10 to 15 times greater prevalence than POAG. The high prevalence of ocular hypertension and its progression to POAG raises several questions. How often should ocular hypertensives be examined? What diagnostic tests should be performed? Can be identified at high risk and low risk for developing POAG, and how many patients will develop visual limitations, and finally, which patients might benefit from early preventive treatment. Ocular hypertension treatment study evaluate the safety and efficacy of topical ocular hypertensive medications in delaying or preventing the development of POAG in individuals with elevated IOP. It also identified the baseline demographic and clinical factors that predict which participants will develop POAG. The entry criteria was age 40 to 80 years with normal visual fields, normal optic disc, and untreated IOP of greater than or equal to 24 millimeter and less than or equal to 32 millimeter in one eye, and greater than or equal to 21 millimeter and less than or equal to 32 millimeter in the fellow eye. So it was phase 1 was conducted from Feb 1994 to June 2002. And patients were randomized to medication group, and IOP was lowered to 20% and equal or less than 24 millimeter. And patients were treated with the anti-glaucoma medications according to the clinician's preference. And observation group, there was no treatment given, and the patients were monitored with 6 monthly visual fields and annual optic disc photos. And reproducible abnormalities noted when there is 3 consecutive visual field abnormalities and or 2 consecutive sets of optic disc photographs abnormality. The summary of phase 1 shows that at the end of 60 months, the cumulative frequency of developing POAG in medication was 4.4%, and in observation group it was 9.5%. So it provided clear evidence of treatment efficacy. Phase 1 did not indicate when medication should begin and if all patients should receive early medication, and is there any penalty for delaying medication. So phase 2 trial was conducted. It was done from June 2002 to March 2009. Medication patients were continued on medication while the observation patients were started on medication. So it was the delayed treatment group. Delaying treatment of OHT increased the cumulative incidence of POAG at 13 years, and there are more eyes with structural and functional damage, more participants with bilateral disease, and there was shorter time to develop POAG, and waiting does not have a large effect on mean deviation and pattern standard deviation within 5 years of developing POAG. So second phase helps to draw conclusion about the management of patients with OHT. Early medical treatment decreased the cumulative incidence of POAG. The absolute effect was seen in high-risk individuals with little benefit of early treatment in individuals with low risk. Another study was the European glaucoma prevention study. There was no statistically significant difference between dorzolamide treated patients and placebo group in reducing the incidence of POAG in ocular hypertension. Based on the OSTS and EGPS study, baseline predictive factors were identified. It include age, IOP, central corneal thickness, vertical cup disc ratio, and pattern standard deviation. So for every 1 millimeter rise of IOP, there was 10% increased risk for POAG. And with increasing age, there was increased risk. Black race people had thinner central corneal thickness, increased cup disc ratio, and increased IOP, which made them more prone for POAG. In OSTS study, there was no evidence for family history of glaucoma, but in Rotterdam study and Barbados study identify family history as a risk factor. Increased cup disc ratio was an independent risk factor for POAG. A 0.1 increase in vertical cup disc ratio, there was a 19% higher chance for open angle glaucoma, and 0.2 decibel increase of pattern standard deviation was associated with 13% risk. Central corneal thickness is a strong and independent risk factor for glaucoma progression. If central corneal thickness is less than 555 microns, the annual risk was 3.4%. But in Indian population, the normal central corneal thickness is between 520 to 525 microns. So if the central corneal thickness is less than 500 microns, it is considered to be more prone for POAG. And risk calculators are present online. It is based on OSTS and EPGS study. And we have to write enter the age, IOP, central corneal thickness, pattern standard deviation, and vertical cup disc ratio. It calculates the probability of conversion to POAG in 5 years. And level of risk over 5 years, if it is less than 5%, then it's better to observe and re-evaluate every 12 months. If the risk is moderate, that is 5 to 15%, consider treatment, or you can keep the patient under observation. If the risk is more than 15%, treat the patient. So treatment is needed when the patient is on high risk. Such patients need more frequent examinations and early treatment. Treatment is depending on the patient age, health status, life expectancy, and personal preference. IOP above 30 millimeters is better to treat. IOP in the mid to upper 20s with risk factors like family history, thin central corneal thickness, increased cup disc ratio, etc. is better to treat. And young patients, one-eyed patients, unreliable patients, patients who cannot do reliable visual fields, or if there is any optic cannot be visualized, or patients who prefers to be treated, and if there is any history of retinal vascular occlusion, is better to treat. Observation is indicated if the patient is older age with shorter life expectancy, borderline elevated IOP, thick central corneal thickness, if there is an inability to tolerate treatment, and if patient prefer against treatment, is better to observe. We discuss a case, a 54-year-old male with IOP 28 to 26, with central corneal thickness 534, with normal perimetry and ossitry, but with family history of glaucoma. I think it's better to treat the patient. Treatment can be medically managed, or selective laser trabeculoplasty is another modality for treatment in case of OST. Thank you.
Thank you, Dr. Smita. Now we invite Dr. Meena Nair to talk on normal tension glaucoma treatment dilemma.
Good morning, everyone. At the onset, I wish to thank KSOS and Dr. Girija for this opportunity. My topic is normal tension glaucoma, a treatment dilemma. Diagnosing and managing NTG is indeed a challenge, especially because IOP is in the lower end of the spectrum. And I feel that unless definite, the genes are identified for NTG, or the pathophysiology of NTG is better understood, we can still consider NTG as a subset of primary open angle glaucoma. In the next few minutes, I shall take you through a few case scenarios wherein I'll bring forth the dilemmas encountered in the management of NTG. Here I have a 46-year-old lady who gave typical history of migraine with aura, and had paresthesia of her fingers and toes, intolerance to cold, and generalized body ache, which the physician put it as fibromyalgia. Note the right optic disc, which is definitely glaucomatous with the bipolar notch and the bipolar wedge defects, and the left eye with a lesser degree of an inferior notch and a wedge inferotemporal defect with thin central corneal thickness and a day diurnal showing a range of fluctuation of just 10 to 12 millimeters of mercury. So what do? Obviously, with such a gross asymmetric advanced glaucoma, you have to treat. So she was started on topical prostaglandin analog, and aiming for a reduction of 30%, and this is evident by the stability in her fields done recently. The fixation threat, the tubular field, right from 2009 to 2022 is maintained in the right eye, and the left eye is absolutely asymmetric. So apart from the routine investigations, I would say that when you have an asymmetric GON, you have to do a thorough cardiology, a thorough neurology, and in her case, a rheumatology to rule out autoimmune etiology also was done. And in the young, I would say a Doppler imaging of the bilateral carotids and the ocular blood flow analysis needs to be done. This was done in her case in both 2009 and 2019, and nothing was detected. This is yet another young man, 40-year-old, but on prostaglandin analog, started from elsewhere since 1 year, now planning to go to Saudi, and came to me asking whether he needs to continue medication lifelong. And a cursory look at the discs, I thought they look more or less symmetric, except for a little tendency to notch superotemporally in the right eye, and he had thick cornea. So I stopped the medication, asked him to come back 2 months later for a 24-hour DVT with 24-hour BP charting, and that was done. And it was within normal limits of just 10 to 14 to 16 millimeters of mercury. So the medication was discontinued, and he's been followed till 2022 last with normal fields. Of course, I would like to emphasize here that when you have this with mild pallor, your OCTs will always, can give you misleading results, and you can think it's a red disease and start treatment. So what do we learn from this? I would emphasize in the management of NTG, diurnal facing, either office DVT or 24-hour DVT has a major role. Central corneal thickness has to be done in all cases, and in the young, a Doppler scan imaging of the blood vessels. And remember always that you would be looking probably at an IOP, which is in the normal phase of a POAG. And again, when you have asymmetric glaucomatous optic neuropathy with no asymmetry in IOP, always think of other causes. The next is a patient who is in 50s with multiple comorbidities. He had diabetic, he had hypertension, and he had coronary artery disease. And the very discs by the beta zone and by the large deep cups suggest advanced glaucoma, as evidenced by the fields which are impinging fixation, and which by the control of all his systemic morbidities very well, he has been maintaining the same central 10-2 fields 2013 to 17 to 19. And after that, actually, I have been finding some erratic fluctuations in BP, when even a thought of whether he should undergo a TRAV was thought. But a good control of his hypertension and cardiology has resulted in even the recent fields giving a similar field defect. This is an elderly 65-year-old woman who came for an ophthalmic evaluation routine. On examination, I found she has bilateral inferior notch, IOP of 12, facing of 10 to 15 millimeters of mercury, and thin corneas. So because of an inferior notch and typical fields, in NTG, when you have fields, deep, steep defects close to fixation in the central 5 to 10 degrees, you have to correlate with the disc with the polar notching. And she was then investigated, thorough cardiology evaluation, and we found that her Holter showed cardiac arrhythmias. She had atrial ectopics and supraventricular ectopics, and the physician had put her on Virapamil 3 times daily, 40 mg, and she has maintained her fields also, as evidenced by the GPA summary, as stable. These are the latest octopus fields done recently, because she had some cataract, so doing the Humphrey was difficult, and we see that the 10-2 fields are showing stability without encroaching fixation as she presented initially. So here we learned that control of systemic comorbidities in a case of NTG is very important, especially hypertension control, looking out for other causes, and avoid the nocturnal dips, because you want to have a good you should not have a low ocular perfusion pressure. When the nocturnal dips occur, you have a risk for a reduced ocular perfusion, optic nerve head perfusion rather. Next is a lady who presented, who was in Maldives and was started on travoprost for a year, and she came for the second opinion, and I realized she had disc hemorrhages on treatment, both in the right eye and left eye. You can see the resolving hemorrhage. So I underwent a DVT on treatment and found that it was not acceptable because she had thin corneas as well. So additional medication was started, and she's expected to come for the review after 6 months. The next is a lady who was seen in 2016, had a tilted disc and a baseline field defect. So it was difficult at that point of time to know whether it was a glaucomatous defect or due to tilt, but because the facing was normal, she was observed. But by 2018, she developed a disc hemorrhage in the other eye. So obviously, she was considered as an NTG and started on treatment. And this is the initial field defect when she presented. And by 2020, when we are seeing her, things are okay. In June, by November, she developed a disc hemorrhage at the inferior pole in the right eye, and she had one in the left as well, which took 6 months time to resolve. So when you have normal intraocular pressures, normal facing, and on treatment, but you find hemorrhages, that too you need to be bilateral, always consider progression. You can see the right eye is stable, but the left eye shows that the LD has showing a linear regression slope. Now the left-right is normal. So what do you learn from this? You have to consider progression. The risk of progression has to be considered. And how did we manage her? We followed up more closely, but a gonioscopy revealed that she is a must at this stage because she was going in for a combined mechanism glaucoma, and that closure was picked up by a revision gonioscopy. Now, this patient was not treated in 2012 when she presented early because, though it was looking like a disc suspect, but because of the normal intraocular pressures, and he presented in 2017 with a superotemporal branch retinal vein occlusion. But you can see that despite that, the fields have been the same, and the fields are still the same. So not all NTGs need aggressive treatment. You have to identify the progressors. And disc hemorrhage always raises the suspicion of progression. Now, this is a patient who was on PG analog and on treatment had normal pressures of 8 to 10, but by July 2021, that is 1 year with me, was noted to have had progressed with fields. So what was done? A sleep test was done, and 80% of hypoxia was noted, and the CPAP was started, and with that, we noted a stability in the visual field defect. Here is an asymmetric glaucoma patient. This person came from UAE with this asymmetric damage and had the central steep defect, and the patient was symptomatic and says that he was having progressive disease. All that we did was a cardiology evaluation, a sleep study, and a Doppler, and we noted that he was a known case of obstructive sleep apnea, but a change of the CPAP mask worked wonders, and he retained stability. So vascular factors as a cause for progression have to be thought of. And finally, this case with tilted disc looks more like a disc with a pallor and not really glaucoma. Patient had dyschromatopsia, and you had color vision reduction and contrast sensitivity degrees, was evaluated in neurology, but we had started anti-glaucoma treatment on this myope, and he has retained his field as well, seen recently. So neurological investigations, when do you advise? When in unilateral cases, when the pallor is disproportionate, when the disc does not correlate with field, and visual fields respect the vertical meridian. So from the cases discussed so far, I would like to convey that no clearly defined IOP cuts off. We don't know which IOP will damage the nerve head further. And like in the high tension glaucoma, you cannot expect a dramatic drop in NTG cases, and you have to consider the non-IOP dependent mechanisms as well. The CNTGS study has shown us that lowering IOP is still the proven treatment. You have to reverse the circulatory deficiencies, correct nocturnal dips, use drugs like brimonidine or dorzolamide and bitaxolol as topical agents. And when the on-medical treatment, when it further progresses, consider surgery. But the dilemma remains how much of lower target or IOP you need. Do not go beyond the episcleral venous pressure. Monitoring is crucial in NTG cases. Identify progressors. And neuroprotection is an interesting area of ongoing research. But mind you, diagnosis and managing NTG, though it requires a lot of persistence and diligence, we can have patients in the future with a well-managed NTG and no progression in fields. Thank you for your patient hearing.
Thank you, Dr. Meena. Now request Dr. Girija to speak about a difficult situation that we face, pseudoexfoliation glaucoma, and how it's a challenge to manage.
Good morning, everyone. Pseudoexfoliation glaucoma, a challenge to manage. So, as all of you know, it's a major risk factor for complications in cataract surgery, and it's the most frequent cause of secondary open-angle glaucoma. And it is not only ocular, it's a multi-system disorder. So, the conversion is always very common, that is PXF syndrome to glaucoma occurs in approximately 30% cases in a decade. A few words about the pathogenesis. It's multifactorial, geographical, environmental, and genetic factors play a role. But PXF glaucoma is not genetically determined. And the conversion to XFS to XFG is considered a result of environmental factors. And the anterior segment investigation test showed that there are elevated levels of the oxidative stress markers and a decrease in antioxidant protection molecules like a low ascorbic acid, reduced ocular blood flow, iris hypoperfusion, and anterior chamber hypoxia. And all these changes can cause the increased nuclear cataract formation, dysfunction of the trabecular meshwork, and zonular fragility. Another thing is that the lamina cribrosa becomes more vulnerable to glaucoma because here the mean peak and fluctuation is very high, and the intervisit IOP variation is also greater. So the vulnerability of the lamina cribrosa increases the optic nerve damage by the unfavorable IOP profile, and consequently progression without treatment is 3 times more rapid than that seen in untreated open-angle glaucoma. And the deposition of the material is seen not only in the ocular tissues but also in heart, lung, liver, kidney, meninges, and blood vessels. Patients with ocular PXF may have a history of hypertension, abdominal aorta aneurysm, angina, cardiovascular disease, and stroke. But the studies are still going on. What are the clinical features of pseudoexfoliation glaucoma? Usually they are asymptomatic, but sometimes with increasing cataract or the glaucomatous visual field defects, they can present to you with defective vision, usually in one eye, but later on the other eye also gets involved. And the materials are seen in the pupillary margin as well as on the lens surface in the typical 3-ring pattern. And there is increased incidence of cataract and zonular weakness. So usually there will be some amount of the pigment, when the deposits are seen, always look for phacodonosis. But otherwise you may miss this, and you can pose for a cataract surgery, and there may be complications. So this zonular weakness is due to the proteolytic enzymes in the PXF material or accumulation of the PXF material at the preequatorial regions of the lens. There are deposition of PXF material also occurs in the angle, and there is increased pigmentation, which is may be irregular. There is a sampholysis line which is seen in corneoscopy. Increased pigmentation has been correlated with increased IOP. So pigmentation might provide a clinical gauge as to the severity of glaucoma. And always do gonioscopy routinely in all cases of PXF to monitor the angle. And in case of shallow AC and occludable angles, always do a prophylactic laser PI or an early cataract surgery, because PXF is a progressive condition. If you wait for longer, the zonular dialysis, the weakness can progress, and you can meet with more complications. And there is a disrupted blood aqueous barrier which leads to flare in the AC. After dilatation, you can see flare in the AC, and after cataract surgery also there is an increased exaggerated inflammatory response. The iris shows flecks of PXF material and pigment deposited on the anterior and the posterior surface of the iris, and there will be atrophic and fibrotic changes in the sphincter muscle. And the poor dilatation in PXF is caused by the atrophic and the fibrotic changes, and also the degeneration of dilator and sphincter muscles. The cornea shows decreased endothelial cell density as well as altered morphology. And there will be flake-like PXF material seen in the corneal endothelium. The accumulation of the material between the endothelial cells and Descemet's membrane is a possible cause for direct cellular degeneration. And the IOP increase, the iris ischemia, and increased flare intensity may indirectly affect the homeostasis. So you have the altered morphology also. The capsular glaucoma or the PXF glaucoma, there is a significantly high prevalence in all cases of PXF syndrome, and it arises secondary to the accumulation of the material in the trabecular meshwork. And a consequence of angle closure, that is, you can get an open angle glaucoma or you can get an angle closure glaucoma due to zonular laxity. So why do you consider it as a challenge? Because it's a particularly aggressive type of open angle glaucoma which does not respond that well to medical treatment, and it has a very fast rate of progression with severe disc damage. And there is the IOP profile is also not very favorable. So what are the risks in cataract surgery in a pseudoexfoliation? Pseudoexfoliative patients are actually they show a 5 times greater likelihood of complications during cataract surgery. The zonulopathy and the iridopathy, everything will make the surgery a challenge. Due to the non-dilating pupil, you cannot do a large rhexis, there is zonular weakness, so the lens will be unstable during the surgery. You can get an unexpected PCR, vitreous loss, etc. So you have to take measures like soft shell technique, that is use of OVDs, then pupillary dilators like rings or hooks, and capsular tension ring, and sphincterotomy, which can lessen the rate of complications. So what is a soft shell technique? Is actually, it's a very helpful technique when you do a surgery in, sorry, I don't have good videos. I couldn't get a video after this topic was selected. Actually, you have to put a dispersive OVD first to coat the corneal endothelium, and you have to use a cohesive OVD to deepen the anterior chamber, flatten the anterior lens capsule, and maintain the adequate pupil dilatation. Never overinflate the anterior chamber because it can stretch the zonules and you can get an unexpected nucleus drop. And posterior, the synechia should be always lysed. Either you can do visco or you can use a blunt spatula, and you have to mechanically stretch and dilate the pupil using iris hooks or rings. And careful manipulation should be done. It is required due to the ischemic fragile iris. And capsule retractors are very useful here, and implantation of a modified CTR suture to the sclera will assure anteroposterior stability of the IOL bag complex, because this is the progressive condition, and you can get the IOL, the decentration, and later on the IOL with the CTR can drop into the vitreous. And the choice of IOL, usually the single piece IOL is preferred because it requires less manipulation. It is better not to use premium IOLs because of unsatisfactory visual outcome. And sulcus placement is better avoided because, again, there is probability of decentration and posterior dislocation. AC IOLs are better avoided. The postoperative complications, always you need a rigorous follow-up because they are more prone for increased inflammation, progressive and endothelial damage. Even though the endothelial damage is not permanent, you have to follow up the patient. Then late complications like progressive destabilization of the zonules, capsular contraction, and decentration and dislocation of the IOL can occur with time. So the treatment of PXF glaucoma is with, initially you can, in open angle glaucomas, you can use anti-glaucoma medications, but you get a poor response. Lasers can be used. They show usually good response to argon laser trabeculoplasty or SLT. Then in unresponsive cases, you can do a trabeculectomy. So newer treatments like trabecular aspiration, where you wash the material from the trabecular meshwork using an externally applied suction device or a trabectome. It's a newer thing. Then Zen implants are tried. Gonio wash is elimination of the material located on the trabecular meshwork and the hydrocorneal angle using pressure irrigation. So that is also a newer technique. So the take-home message is a planned approach is required during cataract surgery in PXF to avoid the avoid the complications. always use advanced techniques of phacoemulsification, or when you are doing a SICS, do sphincterotomy or use iris hooks. Specific OVDs have to be used and capsular support devices in case it's needed. And long-term post-operative surveillance that should be there, because progressive complications, you can get long-term IOL decentration and drop. Thank you. I invite Dr. Roni to talk on medical management, the newer horizons and special situations. And he has another topic, that is role of glaucoma progression detection in treatment modification. He'll be delivering both the lectures now.
Thank you, Dr. Girija. So I'm going to speak to you about a few of the newer drugs that are available to us, some that we're already using and some that are on the horizon, and also a few special situations where we have to be a little careful about medications. So we have been using Rho kinase inhibitors for about 1.5 years now, and we know that it works on the trabecular meshwork by increasing aqueous outflow. There are 2 of them available to us. I'll just briefly take you through the literature there. And one of the first studies was an open label prospective study when they used this drug in POAG, ocular hypertension, or pseudoexfoliation glaucoma. And they found it was reasonably effective as monotherapy, causing about between a 3 to 4 millimeter decrease in intraocular pressure. Keep in mind that most prostaglandins will give you about double this. And when they combined it with timolol or latanoprost, you did see an additive effect. So when you combined it with these are patients who were on timolol before instillation, you did see an additive effect of about 2 millimeters of mercury. With latanoprost, you again saw an additive effect of between 1 and 3 millimeters of intraocular pressure. So both as a first line and as a second line drug, it did show IOP reductions, but the first line reductions were not as high as with timolol or a prostaglandin. But what was interesting here, and this is something that most of us have seen in clinical practice, is that fairly high rates of hyperemia. So even when it's added on as a second drug, you do get significantly higher rates of hyperemia as compared to the baseline. So when you look at safety and efficacy, this is a large study of almost 3,000 patients, people with POAG, NTG, secondary glaucomas, and everything else. And when you look at this, you find that in almost all the types of glaucoma, whether it's ocular hypertension, POAG, NTG, PSC, or secondary glaucomas, you did get intraocular pressure reductions, and they were consistent. And this reduction was actually linked to the degree of pressure. So the higher the pressure, the greater the reduction you got. In the NTG spectrum, you found relatively low reductions in intraocular pressure. This is expected because when it works on the trabecular meshwork, it is limited by the epithelial venous pressure, and you're really not going to get much lower than that. Again, when you look at the 18% had adverse drug reactions, conjunctival hyperemia was the commonest one, but most of us feel that the actual rates are probably a little higher than 18%. What about netasertol? So netasertol, in addition to this, also is a norepinephrine transporter inhibitor, and therefore it inhibits aqueous humor production in addition to enhancing trabecular meshwork outflow. So the ROCKET trial was a phase 3 clinical trial which looked at netasertol to timolol, and they looked at people with pressures of between 20 and 32 millimeters, 20 and 27 millimeters of mercury, and in ROCKET 4 between 20 and 30 millimeters of mercury. Most drug trials actually include patients till 32 millimeters of mercury, and they start at about 24. So just keep that in mind when you listen to these results. So the mean IOP reduction was reasonable, about 4 millimeters of mercury. This is the maximum baseline intraocular pressure, and with netasertol you got about 4 millimeter, with timolol you got marginally more than that. And over time also, you did not see again the same effect that I showed you in people with relatively low pressures. You got relatively low intraocular pressure reductions, and this IOP reduction was consistent over time. So at about week 2 you saw an effect, and after that that stayed more or less consistent. So that tells you that when you start this drug, you can probably call the patient at around 2 weeks to see whether it is working optimally. Conjunctival hyperemia rates were significantly different as compared to timolol, with about hyperemia was on an average twice what you see with timolol. You also had no systemic side effects unless the heart rate differences that you saw with timolol. So this study gave us closer to the real world what we see, about 50% hyperemia instead of the 18% reported in the previous study. Now compared to latanoprost, if the baseline intraocular pressure was less than 26, it was non-inferior. If the baseline intraocular pressure was less than 30, once you included patients with little higher pressures, it failed the non-inferiority test, meaning that latanoprost was little better. And conjunctival hyperemia was almost 4 times higher than with latanoprost. What about nocturnal IOP? Because some of the drugs that we use don't really do that well at night. And what you can see here is that you do see a good reduction from the intraocular pressure, and that reduction happens both at night and during the day. But at night, because the eye pressures go up, the actual intraocular pressure levels are a little higher than what you record in the day, but proportionally, the reduction is similar. So they're a useful second-line drug in our patient. And intraocular pressure reduction is consistent over 24 hours, but keep in mind that conjunctival hyperemia is common, and the reduction is modest, which is the reason we don't consider using this as first line. So, but keep in mind that any new drug you will have new complications. This is Rho kinase-induced reticular epitheliopathy, and typically you will see it in anybody who's got a little bit of a corneal issue. Sometimes you see this sort of picture. It's reversible, it goes off once you stop it. The other drugs which you are likely to see maybe in the next 24 months definitely are the latanoprost Bunod, which is a nitric oxide donating prostaglandin F2 analog, and it targets both conventional and uveicular outflow pathways. So the LUNAR study studied this with about 700 odd participants who were randomized to either latanoprost Bunod or timolol. And what you can see is, compared to timolol at all time points, at different time periods during the study, you saw significantly higher intraocular pressure reductions, which seem to increase. So you can see that the difference between timolol and latanoprost Bunod increased at 3 months. So you saw even beyond 6 weeks a further reduction in intraocular pressure as compared to timolol alone. So in the Apollo study, which was a 3-month double-blind study followed by a 9-month open-angle study, you again found hyperemia and irritation as being the commonest side effect. And the mean decrease in intraocular pressure was between 8 to 9 millimeters of mercury at 3 months, as compared to between 6.5 to 8 millimeters of mercury with timolol. So little higher intraocular pressure reductions as compared to timolol, and a fairly reasonable safety profile except for the hyperemia. This drug is the omidanapag isopropyl study. This is compared with latanoprost and POEG and ocular hypertension. This drug has been used in Japan for some time. The India phase 3 trials are over, and I'll be presenting the results next year, so I can't present the results here. But I will tell you these results from the Japanese study. And this was about 250 patients, out of which they randomized 190. And what you can see here is that compared to latanoprost, you do see somewhat similar intraocular pressure reductions. At week 4, there's a marginally maybe a 0.5 millimeter difference, where latanoprost did a little better than the omidanapag. Again, in terms of side effects, this had a little bit more hyperemia as compared to latanoprost. And the other unusual change that you see with, sorry, it's not that in the slide. One of the other unusual things that you see with this drug is, some patients have an increase in corneal thickness. No impact on the intraocular pressure, but some patients have an increase in corneal thickness, no change in endothelium, nothing else, but it's there. So one of the issues is most of the previous studies that have been done on this have never looked at corneal thickness over time in the patients. So this study did, and they did pick up about a 5, 7, 8, 10 micron difference. So that's an interesting thing. We don't know why it happens, but it doesn't seem to impact your results in any way. This is the bimetoprost sustained release implant, and this is data from the phase 1, 2, 3 study. This is what it looks like. It's on an injector, which is basically similar to Ozurdex. It's a platform technology, and you can see that little thing is injected into the anterior chamber. It has been approved for use in the US, but only as a single time injection. The effect is supposed to last for 3 to 6 months, and there are, in some of the data, they do show the effect lasting for as long as 2 years. But in general, 3 to 6 months is what you see, and you can see that the topical drug is in the green arrow, and the implant is in the blue arrows and the black arrows, and you can see that at 3 different dosages, you see not very much of difference between the two. So that's a fairly useful way of, I mean, it's something which again you might see coming to India in the next 36 months. The travoprost punctal plug has been also tried, and what you're seeing here is intraocular pressure reduction of about 25%. So you saw comparable intraocular pressure reductions at 1 month compared to the topical travoprost in phase 2 clinical trials. One of the concerns with all the sort of punctal plug implants is that it can cause dilatation of the punctum. The punctum starts becoming quite ugly looking after 3-4 months. So that is something which is a bit of a concern. The 2 special situations that I will deal with are children and pregnancy. And the reason I'm talking about this is basically with respect to just a single drug, and that is brimonidine. So if you look at brimonidine, you have a bunch of papers in 1999, apparent CNS system depression in infants after the use of timolol, of brimonidine. So the kids became poorly responsible and lethargic. In fact, some of them went into apnea with the drug. And it's very, very clear that you should not use the drug in children. Therefore, you should not use it in neonates between the age of 2 years. Unfortunately, this continues to happen, and this is a paper published 16 years after that, when this was given to a child with congenital glaucoma who went into respiratory depression. And if you look at the literature, you have between 2007 and 2016, 6 cases reported in the literature itself. So, I mean, as ophthalmologists, this is something that we should not do. You can lose the child because of this. So if you learn, I mean, this is just one take-home message about this. Don't use brimonidine in a child below 2 years. Above that also, if you need to use it with punctal occlusion and warn the parents that this might happen. So you can possibly use beta blockers, latanoprost, dorzolamide, brimonidine, and you need to do punctal occlusion in all. Keep in mind that all the newer drugs that you're getting, we have no information in children. So coming to pregnancy, you have basically class A, B, C, D, and X, with X being unsafe at all. Class D is unsafe because there's evidence of risk in certain clinical circumstances. Class C is uncertain safety, but animal studies show an adverse effect, no human studies done. And class B is presumed safety based on animal studies. Class A is absolutely safe. In pregnancy, we have no class A, in glaucoma, we have no class A drugs. Brimonidine is the only pregnancy class B drug. Class C is everything else. Keep in mind that if you're going to use brimonidine, you have to tell the mother to stop using it the moment she starts breastfeeding because it is transmitted in milk. Prostaglandins, there's a theoretical risk that it might cause uterine contractions and influence fetal circulation, and it's suggested to avoid it in 3rd trimester. There is no evidence for this. This is something that all of us feel. If you remember our gynecology postings, we used to put huge amounts of prostaglandin ointment. I'm not sure this 0.005% will do anything, but it's something that you need to keep in mind. So thank you, and I think I'll switch to the next talk because I'm already running a little late. So I'm going to speak about the role of glaucoma progression detection and treatment modification. So those are my financial disclosures, none relevant to this. Keep in mind that POG is defined as a chronic, progressive, potentially blinding disease. So progressive is part of the definition of glaucoma, and therefore whenever we look at glaucoma, you have to look for progression when you are making treatment decisions. And keep in mind also that the aim of treatment is to preserve the patient's well-being and quality of life. So why do we modify treatment in glaucoma? Of course, we modify it because target IOP is not reached. We modify it because of side effects of medication. We modify it because of quality of life issues. And we modify it because of glaucoma progression. And glaucoma progression and quality of life issues are very closely linked. So if you look at the ocular hypertension treatment study, what you find over here is you found that some patients progressed, and the ones who progressed in the ocular hypertension treatment study were more likely to progress on optic disc findings alone, because that was very early in disease and more disc changes occurred at that time. In the EMGT study, which looked at people with established glaucoma, you find that most of the progression actually happened with visual fields, because once you have damage, functional tests are better at picking up than structural tests. So progression can impact both your structural and your functional measures, and both should be looked at. And when you use a very sensitive field test like the EMGT test, you will find progression fast. And this is only to tell you that it's impossible to assess progression without looking at software. You need to have good software on your machines to look for progression, and you need to use it even if you have it. What about quality of life? So when you look at quality of life, the burden of treatment itself can make you miserable. But that's sort of, once you start treatment, that component does not change very much over time. So once you start treatment, anybody who's on treatment is a little bit more miserable than somebody who's not, but it doesn't get worse over time. Your confidence in the healthcare profession actually gets better over time. The most advanced they have, the more faith they have on us. Anxiety levels are high initially, and they get better because patients know that living with disease is a little better. Daily life becomes much, much more difficult as you get more severe in disease. Psychological, the confidence in healthcare, I told you, gets better. Your psychological well-being comes down. And when you look at vision research quality of life, and this is on the x-axis, you have the mean deviation. And you can see that people who are reasonably good fields had fairly reasonable health quality of life, but once you come down here, you can see that it deteriorates dramatically. So the aim of our treatment is to basically try and keep patients from getting worse than -10, -12, because you do get issues at that time. So what additional, if you see progression on the visual field or something else, what else do you want to know? Because you're going to take a look, you're going to make a decision of what is the diagnosis, how long is it since treatment was started, how much functional damage is there, what's life expectancy, how many glaucoma medications is the patient on, and what are the factors, are there cataract and other precipitating factors, and based on that you will decide whether to escalate treatment, whether you're going to go the medical route, whether you're going to go the surgical route. And I'm just going to share a few examples with you, and we'll take it from there. So I'm basically going to put down the factors that we looked at: progression, field damage, life expectancy, glaucoma drugs, and whether this is late in treatment or early in treatment, whether it's mild, moderate or severe, whether life expectancy is short or long, and the number of drugs that the patient is on. And on this side, we'll go for medication, and the other side will go for surgery. So this is somebody who's a young glaucoma suspect with a family history of POAG. This is what his intraocular pressures have been like over time. You can see that he was fairly normal in the beginning, then he spiked to 22, 23 in between, and at that point we made decisions on treatment. This is his disc photos, which how they look like in the beginning and how they look like now. You can see definite nerve fiber defects in both the eyes. This is what his visual field looks like. This is visual field of over almost 8 years or so, and this is what his OCT looks like. And you can see that the OCT is starting to show some changes in the inferior quadrant. The GCC is also beginning to show you some changes in the inferior quadrant. This is the disc photos in the other eye, and here you can see he had field defects to start with, which are getting a little worse. His OCT parameters are showing very, very marginal changes, nothing much. So he is early in disease. They're seeing only structural changes on the GCC. We're not really sure what the significance is because we're not seeing anything on the visual fields, but he has moderate disease and functional change on that. So the thing to remember here is this is also progression. He has a family history, he has documented progression. This is also something that you need to, and we escalated treatment for him. This is a 38-year-old man who was on treatment with us, and between the ages of 35 and 38, you can see that he's progressing fairly dramatically. Intraocular pressure was on target on 2 drugs. So what do you do now? So this is somebody who's progressing. We actually elected to do surgery, and post-surgery, he has stabilized. So early in disease, you have to look for glaucoma progression more carefully because you want to pick up somebody who's like this, a rapid progressor, and before he loses significant vision, you need to get him under control. So your threshold for surgery in somebody like this is low. The third is somebody with POAG. Now this person also on a beta blocker and brimonidine, you have reached target intraocular pressure. So if you look at only the IOP, you're happy because in your mind this is okay. But once you look at the visual field, he's getting worse. So now the options available to you are medication and SLT. So he is late in treatment. He has mild to moderate disease. He's on 1 to 2 medications. And his life expectancy is long. So basically, because most of the factors favor escalating medical therapy, you can consider escalating medical therapy in this situation. So this is another 58-year-old, similar situation on 2 drugs, target IOP reached. Medications, I would consider a very short trial only here because the defects are close to fixation. So here, because the field damage is moderate to severe, you might just try escalating one medication, see whether you can get something done, otherwise just go in for a surgical intervention on him. This somebody, a young man, 38 years old, on treatment for 22 years on bimetoprost and timolol, target IOP is reached, but he is definitely showing progression. You can see from 99 to 2000 to 2021, there is a change. So the options are medication or SLT. In this case, SLT we are not doing because SLT does not work that well in a juvenile open-angle glaucoma spectrum. And again, long life expectancy is something that we're worried about, but because most of the other factors favor him, we'll just go with escalating medical therapy. The 85-year-old man, PSCG, pseudophakic IOP is borderline on prostaglandin and brimonidine, showing significant change between 2012 and 2020, over 8 years. So once you re-look at the baseline, you find that this change has actually been consistent with time. It's about 3% and 3.2%. So it's not that he's been progressing at this rate from a long time. Whatever we have done hasn't really altered that very much. But his life expectancy is short. So there's no need to be very aggressive here. We can continue escalate medical therapy, and he's not likely to develop anything very severe going forward. Because he's at low risk of visual impairment, you can consider an SLT because that's a good option here because to keep his medication burden low. So this is somebody, it's an ocular hypertensive. We have 18 years of follow-up on him, and these are what his intraocular pressures have been like. So he goes up to 24, 26. That's more or less the highest we have seen. And we have one low pressure. I don't know why, but otherwise he's been fairly okay. And this is his combined progression report for both the visual field and the OCT. It looks a little busy. I don't want you to get very confused with it, but you can see on the lower pictures that the OCT is showing some change, especially on the GCC. This is in the other eye. So now the question becomes, you are seeing this progression on an OCT. He's getting worse. And the question is this progression age-related or disease-related? Keep in mind that the OCT has no progression for a group of stable glaucoma patients. It also doesn't know, we also don't know what is the normal age-related loss on the OCT. So in this patient who's an ocular hypertensive, who's fairly controlled, I would not change treatment based only on this because I'm not really sure of the technology which is giving me information on progression. If I was seeing this on a field, I would definitely have escalated treatment. So when you make a decision in progressing glaucoma, you have to keep all these factors in mind. You have to look for progression. You have to look at your target intraocular pressure. You have to look at age, life expectancy, and threat to vision before you make a decision. But very, very important, I'm glad you put this topic in this presentation because target IOP is not the only thing to look at. You have to look for glaucoma progression. Thank you.
That wonderful presentation. So the glaucoma progression assessment, actually it's very important, and the proper software, if available, should be made use of, and it will help you to modify your treatment according to disease progression. So he has explained it very well. I think we come across such situations in our daily life, in our daily practice, and his lecture will help us to proceed in our management. Thank you, Dr. Meena, for that wonderful presentation and those case scenarios. I think the time is over for our session. If there are any doubts, Dr. Meena, young patient, a 25-year-old patient, if he is coming with a large disc and the visual fields are normal, and the OCT.
Young people don't get NTG. If you see it, either you're missing an IOP peak somewhere, or there may be an underlying neurological or vascular issue. So imaging is only when there are unusual situations in NTG. I will not image every NTG. Somebody who's 60 with migraine comes to you with classical, notch and disc hemorrhages, I'm not going to image. An NTG who's progressing very rapidly, or a young man with NTG or a young lady with NTG, I would consider imaging.
I have a question to ask, how do you differentiate a fast progressor with respect to the trend analysis? Do you have any cutoff for the rate of progression?
So normally a stable group of glaucoma patients will be progressing at between 0.5 and 1 decibel per year. So if initially in treatment they're progressing at more than 1.5 decibels per year over the first 2 to 3 years, first 3 years, I would definitely consider them as rapid.
Thank you, sir, and thanks, Meena, for that wonderful discussion. I think we'll wind up the session and give way for the next session.